36-year-old woman has 3 days of painful right eye, blurred vision and tearing. She has eczema managed with topical betamethasone valerate 0.025% and occasionally wears the soft contact lenses overnight. She frequently swims 3 times weekly. Slit lamp examination of fluorescence staining is shown in Figure 7. Which is the most likely diagnosis? A. Acanthamoebic keratitis. B. Bacterial keratitis. C. Corneal abrasion. D. Exposure keratopathy. Or E. Herpes simplex keratitis. The correct answer for question 3 is E. Herpes simplex keratitis. We can see in Figure 7 the characteristic appearance of a dendritic corneal ulcer, which is in keeping with the diagnosis of herpes simplex. Keratitis is an inflammatory condition of the cornea, characterized by corneal edema, infiltration of inflammatory cells, and ciliary congestion. They are typically associated with infective corneal ulcers and therefore are potentially sight-threatening, requiring an urgent ophthalmological review to assess for further deterioration of visual acuity. There are 3 main causes of keratitis, the first being bacterial, which is predominantly associated with Pseudomonas aeruginosa. Investigations to confirm bacterial keratitis includes corneal scraping and microbiological analysis to confirm and identify the causative organism. Management involves topical fluoroquinolones such as levofloxacin. The second type of keratitis is acanthamoebic. Risk factors for predisposing patients to developing acanthamoebic keratitis includes contact lens use, swimming, and corneal trauma. A confocal microscope revealing a pear-shaped cyst is characteristic and in keeping with a diagnosis of acanthamoebic keratitis. Management involves topical polyhexamethylene, chlorhexidine, and propionamide drops. The third keratitis cause is herpes simplex, which is predominantly associated with primary ocular HSV infection or reactivation. Slit lamp examination with fluorescence staining reveals a characteristic appearance of a dendritic ulcer. Management involves topical acyclovir 5 times daily for 2 weeks. Here we have 3 examples of keratitis between Figure 8a and Figure 8c. The first example is in Figure 8a, demonstrates a patient with bacterial keratitis associated with contact lens use. There are 3 distinguishing features which we can observe which allude to a diagnosis of bacterial keratitis. The first is hyperpyle, as shown by the pus collection in the inferior margin of the anterior chamber, followed by number 2, which is a reddened sclera, as well as eyelish discharge as a third distinguishing feature. Moving on, in Figure 8b, we have an example of acanthamoebic keratitis. There are 2 main features which we can see here. In the first white arrow, we can see a ring-shaped infiltrate, and the second arrow in the periphery is hyperemic conjunctiva. Lastly, in Figure 8c, we have a classic example of fungal keratitis, as demonstrated by the feathered margins.